this deep ray. And so it's lateral to the inferior epigastric vessels. So most of the abdominal hernias go out from this orifice. It's a defect in our abdominal wall. And part of hernias go out from this region. This triangle is very important, very important. It's also very common in your examinations. We call this is Hasselbalch's triangle. Please remember its border. The border is inferior epigastric vessels. This is inguinal ligaments, and this is the lateral edge of the rectal muscle. So this triangle, please remember this triangle. So please remember, if the hernia go to this orifice and come out, we call this is indirect hernia. Indirect hernia is the most common inguinal hernia. If the hernia go out from this region, from this triangle, we call this is direct hernia. Direct hernia. So the direct hernia, I think. So we will have a very important discussion is the difference between the direct and the indirect hernia. They always appears in your examination. So we will, if we know this anatomical difference, other issues is very easy to understand.
What is the content of Hasselbalch's triangle?
Content? Okay. If you look back, you will understand. All here are all aponeurosis. We go back. Okay. I think, here is the external ray, and this region is internal ray, and here should be the triangle, right? You see here, the external oblique muscle here is aponeurosis, and here also aponeurosis. Transverse abdominis here also aponeurosis. So you see this vessel, this is inferior epigastric vessel. So actually this one, epigastric vessel and lateral edge of the rectus muscle, and this is ligaments. So actually this triangle is from outside this triangle. So in this region, all the muscular layer become aponeurosis. So when you grow old, become an elderly patient or very weak, it become a defect because the muscle is strong and tough, but the aponeurosis is easy to erupt. And when your nutritional status have problem or people become old, it's always become a defect. So I will talk this later. So close look here. Close look here. Remember? Inguinal ligaments, rectus sheath, and here inferior epigastric vessel. So this triangle is here. 1, 2, 3. So of course, if the hernia comes out from the internal ring, it should come out here. Actually, it's here. So this is the deep ray, internal ray. So from here is the indirect hernia. Indirect hernia. We go down. So this, I have talked about this thing. So please remember, inguinal canal. Inguinal hernia. So please remember, the anterior is skin, superficial, fascia, external oblique aponeurosis, anterior. And the posterior is transversus fascia. And the superior, conjoint tendon. And the inferior is inguinal ligaments. So it's possible to test you to make out what is inguinal canal and what is their borders. So please remember this. And another more important is Hasselbalch's triangle. So I think it's easy to understand. So the stereotic view of the hernia. You see here, this actually is the deep brain. The deep brain spermatic cord from this transversal fascia, transversalis, actually conjoint tendon, and here this layer is external oblique muscle, and the spermatic cord go out here, and then should go down to the scrotum. And the hernia, this is hernia, the sac of the hernia. It was composed of, usually it's the intestine, sometimes it's omentum, sometimes other things. So the intestine is the most common contents. So it was getting to the orifice, the internal ring, along with the spermatic cord. So this is the hernia. So if the patient is clear, the orifice will have a reversible mass or a bulge or a lump in the inguinal region, and you will complain about this. So remember, this is the typical image of the hernia.
After this region, there will be intestinal content. After this region, the hernial sac. Here, the intestine will be after this region, coming from the ring.
What?
The intestine. If we enter the ring, it will be to this region.
Into the ring?
Yeah.
Yes. The contents go into the deep ring, and then along with the spermatic cord also pass through this.
The intestine itself.
Intestine.
Only the content of the intestine.
No, I will talk later. Only first is the content is intestine. Yeah. I remember.
So if the content is intestine, the people they have hernia, right?
Yes.
So then it means that there is bowel obstruction.
Yeah, it's possible. So I will talk about it later. Yeah, very clever. It's very smart decision, I think. Yeah, of course, it's getting inside will go the stricture of the bowel. Of course, will cause obstruction. But the problem is, because
my question is that people have hernia like for very long time, months and years, but they don't complain of, they don't have any problem of.
Yeah, it's possible. Of course, it's possible.
So
Because
I don't understand how is it possible, because there should be obstruction.
Yeah. Right. Because the content come out. It's not content itself. It have peritoneum. Because just like the peritoneum also will stretch, also go out. So it have a sac. So this status of hernia actually is reversible. We'll talk this is reducible hernia. Another kind is irreducible hernia. And another is incarcerate hernia. And then strangulate hernia. I will discuss later. First, this is I just show you the anatomy. Yeah. So you see here to go out the steroid. So this is internal ring. So if the defect is here, 3 layers of aponeurosis. Actually, this is the epigastric arteries omitted. So the omitted go this way, and this is the rectus sheath, and here is the ligaments. Actually, if you go out this region, this is direct hernia, and this image is indirect hernia. Please remember. Why cause direct hernia? I don't know.
I have a question. Can you, where is the Hasselberg triangle here?
Here. It's here, you see? Because this is a stereotic view. It's very difficult to describe the triangle, but we can have a look here. You see, this is the femoral vein, femoral artery, and this is epigastric vein and artery. So it goes this side. The lateral edge of the rectus abdominis. So you see here, rectus abdominal muscle. So the lateral edge is here, and the ligaments should be here. So this triangle is 1, 2, 3, I think.
This is the Hasselberg.
Sorry. So if you go out in this triangle, it becomes direct hernia. Maybe direct is this means just go out without a reason. Just go out. It's direct, and it's go out from together with the spermatic cord. Direct. I really cannot understand why this terminology. Okay. So this is look from inside. It's a true image by laparoscopy. When we look from the abdomen, we will find some. You see here, this is deeper A. So the spermatic cord is getting this way. And bladder, it means bladder. Bladder means this is in the middle, because urinary bladder is here. So there's some umbilical fold. We just omit this fold. So actually, this is a female patient. Is the best difference. Yes, best difference. Best difference go out from this deep inguinal ray, and yeah, the information you get is here. It's from inside. It's look like this. So this is the inguinal hernia in a child. You know, the scrotum is go out here. Scrotum, I think, go out maybe from this is inguinal ligament, and this is deep ray, superficial ray. Just by this, we cannot know. So another very important thing is if the hernia descending into the scrotum, it means it must go together with the spermatic cord, so it must be indirect hernia. Okay. Another term is the hernia sac. The hernial sac means, this is the contents of the hernia. Usually it's the intestine, and here is the peritoneum. The peritoneum will protrude together with the intestine, and then this is the like skin superficial fascia. Here we call this is the neck of the sac, neck of the hernia. This is content of the hernia. So this is illustration. And to etiology of so now we turn to, I think we have learned about the anatomy of this region, so we begin to talk about something. First is the etiology. So common factor, there are some common factor. I have told you there is defect in our human beings, like inguinal region or some other region, which any factor that cause a defect will all is the common factors of the hernia. Look, this is bad development of abdominal white line, so it's epigastric hernia. Incision, trauma, infection, or everything, any defect in collagen synthesis neuroma, like some metabolic disease, inbound congenital disease disorder, we also call this problem. So why all the people upright, all the people walking, some got hernia, some not? This is, I think, the internal factors. And any other conditions which increase intra-abdominal pressure will also cause hernia. Usually, like I will show you, like chronic cough, constipation, dysuria, aside pregnancy, or like children always cry. Cry is also a problem. It will cause increased abdominal pressure, which will cause problem. You see, I show you here a lot of factors. I hope like coughing, chronic obstructive pulmonary disease, asthma often cannot breathe out, will cause increase of the abdominal pressure. Constipation, pregnancy is easy to understand because you have a child in your abdomen, so also gravity is increased. The body weight, high body weight, family history, sinus. So I think the most important reasons in the clinical is coughing, constipation, pregnancy, ascites. Because how to say this is usually in clinics, the older people they all have these problems. The elderly, they have poor nutrition status, so and plus the increase of abdominal cavity pressure, they will cause a problem.
How the birth weight less than 1,500 grams will be the factor for hernia? Birth weight.
No, not really. I think this is just risk factors. Not all the people less than this body weight will cause problem. This just is a risk factors. Understand?
Why?
Because they are.
Canal will be removed.
Yeah. Usually, I think the baby less than this kilogram always call this is pre-birth, usually pre-birth child. And this child, we have development, the fetal development will, all the sheath and the abdominal defects will evolute, will join together, and the testicle will descending. They need time. And when the child was birthed like this, they have not developed well. So usually have this problem. So this is risk factors. But do remember some important risk factors like coughing, obesity, constipation. The side it's very easy to manage in clinics. And old age is also another problem. Many patients, the prevalence of the hernia developed with the increasing of the age. Okay, now let's turn to a very important issue is clinical manifestation and diagnosis. I think the symptom of hernia is various. It really depends. Sometimes the people with hernia they did not develop any symptom. They don't know they have hernia. We have talked about the symptoms of the hernia. Usually, as we know, the symptom of hernia is quite various. Different patients. Some people will feel a lump in inguinal region. Some people will just feel nothing at all. And some people will feel a very special kind of discomfort in the inguinal region, like discomfort, pain, or a dragging sensation. You can go down, and you will feel something's dragging. So this is the symptoms. The patient usually the signs is a reducible or irreducible lump, and a very interesting symptom is there's a lump. So you have asked me a question. Since the hernia will go into the internal ring, why it did not cause intestinal obstruction? This is the reason. It's reducible. Can go out, come back. It's free. It's free. So usually most of the hernia are free. So it won't cause problem. It's just the hernia, the sac of hernia has become part of the abdominal wall. So this is part of the abdominal cavity. So And when your pressure increase, abdominal pressure increase, how to increase? Cough. It's one way. Cough, urination. So when you check the patients, you cannot tell him, please urination. No, you must say, please cough. Cough, and the lung go out. And or sometimes let him walk. Just walk fast, or make some, I don't know how to say English, like this, and then pressure increase, and the lung go out. So this is design. And then we have
the urination increase?
Yeah, it's urination. Try it. No, urination. The bladder have to compress. Compress, you know? Compress means the pressure increase. I think the stool will cause more pressure. so you know, try, cough, urination, and constipation, and sinus, pregnancy. Because remember these factors, all will cause increase of abdominal pressure. Then we will see. Reducing the hernia falling, compress the internal ring. See, we control indirect, not control direct hernia. So we go back. Look at this. We use a method to control internal ring. How to control? So we know this is a landmark. Here is the pubic tubercle. Here is the iliac crest, and in the middle, and above one finger. This region, because this is the superficial marker, landmarker of the internal ring. So when your patient goes to you and you let him into the bed and make a supine position, and then because the pressure increase, so the lung come back. So this time you use your index finger to push, compress this point very deep. Push this, and then let him stand up. Let him stand up and cough. And this time pressure increase. So if this is indirect hernia, it should go out this way, but because of your finger there, it did not go out. But if this is a direct hernia, it go out here. It go out here. It's a direct hernia. Although your finger there in the deep ring, it still come out. So it's then cough did not go out. You release your fingers from the internal ring. It came out, so it can be confirmed by this maneuver. That means this is an indirect hernia. It's really very important in clinical jobs. I think this afternoon maybe you will go to the clinic. I think they will show you some hernia patients. You can try this. And can in bed and then put the deep ring and then stand up and then.
Professor, can you explain the maneuver again?
Okay, I
What do we call? What is the name of this maneuver?
No name. It's just the experience. No name. So I repeat again. Tubercle vessel, pubic tubercle, iliac crest. So find these two landmarks in the middle, above one finger. This is the point of internal ring, and then press your index finger deeply in this side. I mean, control the deep ring. Then let the patient walk or cough. If the hernia come out, it means it did not go this way, it go this triangle. So this is direct hernia. If it did not come out, then you release your finger. If it come out, it must be an indirect hernia. So this please remember this maneuver. It's really very important. Then we have another maneuver you see here. So this maneuver is controlled deep breathing, and this one is not clear here. This one should be more clear. This is a live person. So your index finger get into the most dependent part of your scrotum, get into scrotum, and oblique to touch what? Touch the external ring. External ring must through the scrotum into the, so you can feel the external ring. Then, if this is a inguinal hernia, so this maneuver cannot differentiate the indirect or direct hernia, but it can touch the hernia. If you feel him cough, you feel a pulse into your index finger. It means this is a hernia because it go out. If you cough, the